If you're doing an LMA or an endotracheal tube, then have everything laid out and ready to go. So after you've induced, you just slide that in. And this video is not really about like having the appropriate setup. It's more of developing that plan of care.
Hello, future CRNA. Welcome to CRNA School Prep Academy podcast. I have a very special episode lined up for you today, and it is part of our guest host series where I am bringing current SRNAs on the show for you as a guest host on the CSPA podcast. And my thought process behind doing this is I wanted you to hear from current students, a variety of current students who are at different stages of their CRNA journey, and really allow you to kind of step into their world and hear them talk about what it's like to be a current student dealing with things like difficult preceptors or different anesthesia topics, clinical topics, maybe even things like time management, stress management, things like that. I think these episodes are going to be gold, and I hope you enjoy as much as I always do hearing from current students. I know for a fact that the reason why CRNA School Prep Academy is where it is today, and the reason why I have learned so much, is from diving all in, listening to current students along with CRNAs share a wealth of information and really kind of taking all of that information and kind of compiling it into kind of the system that we have created today. And I know that you're doing the same thing by tuning into the show week after week, developing your own method, your own strategy, and your own system for success. So I hope you enjoy these guest episodes. Let's go ahead and get into today's show.
What's up, everyone? I'm David Warren, and welcome to the CRNA School Prep Academy podcast. I'll be your guest host today. I'm a second-year nurse anesthesia resident out on the West Coast in California. I'm in my second clinical rotation, and today I want to talk to you about how to prepare care plans for your patients in anesthesia school. I want to tell you first what this episode is not going to be about. So this episode is not about how to stay up late and how to write the perfect care plan. That's not at all what I'm talking about. I really want to focus on showing up to clinical, being presented with a patient, and then developing a plan of care based on that patient. And I'll give you some real life examples of that because at my current clinical site and my previous sites, I did not have access to my patients the night before. So I couldn't go in and look up anything about the patients. I couldn't even go and look up the surgery. I show up on day one of clinical or day two or whatever day it is, and I'm presented with a list of surgeries and patients, and I have to come up with a plan of care. Sometimes the CRNAs wouldn't show up until about 15 minutes before the patient rolled back. So I really had to, from scratch, develop that plan of care myself. And so there are some sites where you go or where I will go where we have access to look up the patients the night before, and that certainly helps. But I really want to focus on the nuts and bolts of showing up to clinical and being presented with a case and then being able to develop a plan of care pretty much on the spot for that case. Now, I will preface this episode with this as well. This is not really referring to your specialty rotation. So we're not going to be talking about transplant anesthesia or cardiac anesthesia or really any of the big major surgeries. I really want to focus on 90% of the surgeries that you will do as a CRNA. So of course you can work in specialty areas as a CRNA, but if you're working in a community hospital or a critical access hospital, or you're working in an independent CRNA practice, there are a handful of surgeries that you're going to be doing 90% of the time. And those are the cases that I really want to focus on and talk to you about today. And this is more of a broad general overview. It's not necessarily getting into the weeds of how to develop those care plans on the fly, but it's more of broad general 30,000 foot view of how to develop a care plan or how to develop a plan of care for your patient whenever you haven't seen them and you don't know anything about them and you've got about an hour to do it. So that's really what I want to dive into today. And I really want to take you through my process of doing that, kind of how I do it and how I break it down in clinical now. And so at my current rotation, I'm in my second rotation, and I will show up to the hospital and find out day of what procedures or what surgeries I'm going to be doing that day. And so when I go into the hospital, I'll get changed to my OR scrubs. I'll grab a list or I'll look on the computer and see what room I'm assigned to. And then I will take the first case of the day and then see what that particular case is. And so let's just say it's a laparoscopic cholecystectomy. And so that's going to be the first case of the day. And I'll really look at that from the standpoint of what broad type of surgery am I going to be doing today? Is it general surgery? Is it urology? Is it GYN? Is it robot surgery or is it orthopedic surgery? Am I in OB? Like all of those different types of surgeries really pull my brain in different directions as to what I can expect and what I can do during those cases. And I will say this, it takes some time. I'm 4 months in. It takes some time to be able to look at a surgery and say, okay, I'm going to do X, Y, and Z for this patient. You do learn some of that in school, but it's a little bit different whenever you show up in the clinical setting and you're doing that within an hour. And it's not like in sim lab where you have weeks to develop something before your check off. So it's a little bit different, but you do get some of that background in school, but it is different showing up and being presented with a case and saying, okay, I'm going to do X, Y, and Z. And so I will start by looking at whatever that first surgery is. Let's say it's that laparoscopic cholecystectomy. Let's say it's robot assisted. And so I will know just based on that I'm going to be doing general endotracheal anesthesia. And so that's kind of where I start is what broad type of anesthesia do I want to do for this case? Do I want to do a general anesthetic? Do I want to do a sedation like a MAC or a moderate to deep sedation? Or do I want to do neuraxial anesthesia? Do I want to do regional anesthesia with some sedation? There are many different ways that you can break that down as to what you want to do. But based on that surgery, I will then say, okay, like if it's a laparoscopic cholecystectomy, I know I'm going to be doing general endotracheal anesthesia. I know based on the fact that they're going to be insufflating the abdomen, that's going to put significant pressure on the lungs and the airway. So I need an ET tube. Like I'm not going to be doing that under LMA. Side note, there's some countries that do laparoscopic procedures under LMA. However, in the United States, it's not really common at all. I've never seen a laparoscopic case under LMA. Maybe you have at your institution, maybe that's something you practice. And that's another point that there are about 10,000 different ways to do anesthesia. There are maybe 5 or 6 of those ways that are wrong, and the majority of them are right. They're just different. And so, depending on what rotation you go to and what hospital you're at, will really dictate some of the odds and ends of what kind of anesthesia you're going to do. Because the culture at one particular hospital may be completely different than the culture at your next rotation. And so you're going to be doing different anesthesia for very similar, if not the same procedure. And I would say that that's really good because you get a different experience on doing different methods of anesthesia for the same procedure. And you can see what you like and see what you don't like. It's kind of frustrating initially, and I can see how it'd be frustrating saying, okay, I had this plan lined up and I want to do X, Y, and Z. And then somebody says, no, we need to do this, and this. And that can initially be frustrating, but it's really cool to see that you can do different things for the same procedure and it still work out. And one may work better than the other. And if it does, then you'll know that's what you want to do the next time. And so again, I really start by looking at that procedure, and that will really determine for me what type of anesthetic I need to provide. Do I need to do general anesthesia? Can I get away with sedation or neuraxial or regional? So that's kind of how I start initially. And I get that initial plan in my mind. Okay, I'm going to be doing a general. The next question I would answer is, do they need an endotracheal tube or can we do an LMA? And so a hard and fast, I say a hard and fast rule, a very loose rule, a pretty hard and fast rule at my clinical site. And most clinical sites, I would say, if the patient requires paralysis, then you'll not use an LMA. You don't want to give 50 of rock and then put in an LMA and then risk the patient aspirating. And so I would say in like over 90% of places that, and people that I've talked to in places that I've been, you don't paralyze with an LMA. And that may be different where you rotate. There may be places out there and people out there that do that. And that's not necessarily wrong. I could make an argument that it is wrong, but it's not necessarily wrong. So that's my next question. Do I need an endotracheal tube or can I get away with an LMA? Obviously, that's for general anesthesia. If I'm doing sedation, I don't need an airway at all. Maybe I need an oral airway or something of that nature, but the patient will be spontaneously breathing. And so I'll determine, do I need an endotracheal tube or do I need an LMA? And so there are a lot of cases that you really could make an argument for either. You would never be faulted for intubating somebody. If your gut instinct says this patient needs to be intubated, then you should probably intubate the patient. If you have to talk yourself out of doing an intubation, you should probably intubate the patient. And some of the factors and some of the things that we look at on LMA versus endotracheal tube is going to be things like acid reflux. Do they have GERD? I go talk to the patient and Usually I know for like our laparoscopic cholecystectomy, they're going to get a tube, like no matter what, even if they didn't have GERD, even if they didn't have a full stomach, they're going to get a tube anyway. So that's a moot point for this particular case. But on any other case, for a general anesthetic, I would ask, do they need a tube or can we get away with an LMA? And so some of the things that would differentiate that, like acid reflux and GERD. So does the patient have daily acid reflux, or have they had acid reflux today or last night? That would let me know, okay, yeah, if they lay down and they have stuff coming up in their throat, I should intubate the patient because they're high risk for aspiration. And so LMA versus ET tube really comes down to what is their risk for aspiration? And so do they have a full stomach? Are they a trauma patient? Do you know when they last ate? If they're a trauma patient, they're going to get an ET tube. Like you consider a trauma patient full stomach. A pregnant patient, you'll consider a pregnant patient a full stomach by like 19 to 20 weeks. And so you would RSI and endotracheally intubate those patients. But otherwise, if they are at a low risk for aspiration, so they don't have GERD, they're not on a GLP-1 agonist like Wegovy or semaglutide, something like that, where they could be considered to have a full stomach, then you could opt for an LMA. If they have uncontrolled diabetes, they're going to have autonomic neuropathy, delayed gastric emptying, gastroparesis. They're at a high risk for aspiration. You could certainly make the argument for an uncontrolled diabetic or a diabetic that is controlled, that has had diabetes for years and years, that they have that autonomic neuropathy, and the safer option would be to intubate the patient. Now, there's so much gray area here. I've been with preceptors at my prior site who, if the patient even looked like they might have diabetes, they got an endotracheal tube. And then I was with other preceptors who we had a patient who was like 300 pounds on, had uncontrolled type 2 diabetes and on semaglutide, and the preceptor was like, "I'll just do an LMA, it'll be fine." And the case was fine. The LMA worked well, but things work well until they don't. And so whenever you have that bad aspiration with an LMA that you probably should have intubated, you probably won't make that mistake again. And so it really comes down to what is their risk of aspiration when it comes to airway. And so pretty much any laparoscopic case, like I said earlier, is going to get the endotracheal tube. So I would know lap chole, getting an endotracheal tube, doing general anesthesia. And the next question would be, what is my induction going to look like? What do I need to do for induction? And there are a million different ways to do this. You want a medication that would blunt the sympathetic response to laryngoscopy. We can do things like fentanyl. You can do esmolol, a selective beta-1 antagonist. You can do dexmedetomidine. In my experience with fentanyl, if you give 100 milligrams of fentanyl at induction, and then you give the rest of your induction meds, and you're hooking them up, you got them intubated, you hook them up to the circuit, you turn your gas on, here in a few minutes, they will go very hypotensive. And so my experience with fentanyl is, if you give the 100 milligrams at induction, expect some hypotension pre-incision, post-induction. And so you would have to treat that. And so it's something you keep in mind. Is there a right way to do it? It really depends on the patient. If you have somebody that has a labile blood pressure to begin with, it's probably best to not give them 100 milligrams of fentanyl and tank their blood pressure even more. And so that really goes into some of the art of anesthesia, and knowing, based on the patient's comorbidities and risk factors, what do my induction meds need to look like? And so if they have aortic stenosis, you really don't want to slam 200 milligrams of propofol and kill the patient. So maybe we would opt for a ketamine induction. And, in somebody that's otherwise healthy, you can really get away with a lot of different things and it not be right or wrong. This really becomes an issue when you have sick patients who are hemodynamically unstable and have significant comorbidities in their life. And those are the patients that you would alter your induction plan. And so this really comes down to doing the preoperative assessment, doing a really good pre-op. Go talk to the patient, go through each system, find out what medical problems they have. Do they have heart problems? Do they have lung problems, et cetera? And that really will guide your induction sequence and what medications you would use. So if it were a young person, 20 something years old, no medical problems, you could really get away with any induction that you wanted to do. Now, if it's a 90-year-old with an ejection fraction of like 20% and aortic stenosis and, all the things, then obviously we probably shouldn't be doing an elective case on that person. If it's an emergent case, that's a different story. But you would obviously change your induction plan to be a little bit different and more hemodynamically stable than you would be for, say, somebody who's 20 something years old. And so your induction plan comes next. What are you going to do for induction? We would have fentanyl or something of the like to blunt the sympathetic response to laryngoscopy. we would often give lidocaine IV. Lidocaine does two things. So it will also help blunt the sympathetic response to laryngoscopy, and it will also help kind of numb up the venous tract of where propofol will follow right behind, because propofol is very irritating, it burns, and the lidocaine will help decrease some of that. And then we would give something to render the patient unconscious. So something like propofol or ketamine or etomidate or something of that nature. You could even do a fentanyl induction. I've read about that. I've never seen a fentanyl induction done. They do that on some cardiac patients. The fentanyl becomes a problem when you combine it with other agents. So fentanyl alone is not going to cause significant hypotension, but fentanyl combined with 200 milligrams of propofol and gas will cause significant hypotension. And so that really comes down to what induction agent do you want to use to render the patient unconscious so you can paralyze? Do you want to use propofol? If so, how much propofol do you plan to give? Do you want to use ketamine? Do you want to use ketofol? Do you want to use ketamine and propofol mixed together? You will eliminate some of the hypotensive effects caused by propofol when you mix those two drugs together, because you're giving a little bit of each and not a whole lot of one. And so they kind of even each other out. And then what paralytic are you going to use? How long do you expect the procedure to be? Is this going to be a like 30-minute procedure? Can you get away with doing succinylcholine and then giving like 10 to 20 milligrams of rock to kind of toe the line? And a lot of that is really, paralytic wise, a lot of that is going to depend on whether or not or what reversal you have available. Do you have Sugammadex available, or are you going to be reversing with neoglyco? And so knowing your pharmacology really comes in handy in this, like really in anesthesia in general, but especially during the induction phase as to what medications you're going to give. So if this is a 10-minute laparoscopic procedure, I'm not going to give 50 milligrams of rock if I don't have Sugammadex available. I may give 170 to 100 milligrams of sux up front, and I may give 10 to 20 milligrams of rock to keep the patient slightly relaxed, but not fully paralyzed. And so if I have Sugammadex available, maybe I will give that 50 of rock, and then I could just reverse, in 30 minutes to an hour when the procedure's done with Sugammadex and still keep the patient very densely blocked all the way up until I want to reverse. And so the procedure length and duration will determine what paralytic you use. There's no right or wrong way to do that. Can you use succinylcholine if it's not contraindicated? Sure, absolutely. Can you use rocuronium on pretty much any patient? There's not really a contraindication to it. Yeah, you can. But you really have to think about what reversal agent do I have available and how long is the procedure going to be when it comes to paralysis, because if you don't have Sugammadex available, you can bite yourself very easily by giving that 50 milligrams of rock and then the procedure being done in 15 minutes. You're like, holy cow, I'm not gonna have any twitches back. And so for those of you who haven't had that pharmacology sequence, to reverse with neostigmine and glycopyrrolate, you need at least one twitch back. And so they can't be super densely blocked to reverse with neostigmine and glycopyrrolate. However, with Sugammadex, they can have 0 twitches back, be very densely blocked, and you can give Sugammadex right at the last second, and they will be back within about a minute or two. And so it really comes down to what reversal agents do you have available and what's the culture. So at my first clinical site, the culture was to give every single person Sugammadex. At my current clinical site, it's kind of an unwritten rule, like nobody gets Sugammadex unless there's some compelling reason. Now, if it's like a 90-year-old grandma who has a bunch of comorbidities, sure, Sugammadex is fine. But if it's like a 20-something-year-old person and they already have one twitch back before you reverse, like give them neoglyco. And so a lot of that's going to be culture dependent. And so that will also guide your paralytic choice as to what reversal agents you have available. And then after induction, you want to know what type of airway am I going to do? So we covered this earlier. Am I doing general endotracheal or am I going to be doing an LMA? And so if you're doing an LMA or an endotracheal tube, then have everything laid out and ready to go. So after you've induced, you just slide that in. And this video is not really about like having the appropriate setup. It's more of developing that plan of care. Then we go on to the maintenance phase. So what is your plan for maintenance for this patient? And there are really 2 broad categories that we can talk about. And that is, do you want to do gas or do you want to do Ativa? And so gas is going to be either sevoflurane, desflurane, or isoflurane. And I will say 99% of cases you'll use sevoflurane unless there's some compelling reason to use something else. In fact, it's kind of a side note, but at my current clinical site, I looked at my numbers the other day, and I have like 200 something cases of using sevoflurane, like 13 cases of using isoflurane, and like 12 or 13 cases of using desflurane. And so at my current clinical site, I went and found an isoflurane vaporizer, and I was like, okay, I'm going to start using isoflurane just to get used to it, because I've used it, as many times as I can count on two hands. And so I really want to get used to all the gases. And so I kind of made a pact with myself at my current clinical site. I was like, I'm not going to use sevoflurane for the rest of the quarter. I'm just going to use isoflurane or desflurane. And so for sevoflurane, you can use that on pretty much anybody. So there's like one major contraindication to any volatile anesthetic, and that is malignant hyperthermia. So as long as the patient doesn't have MH or a risk factor for MH, like a close family history, then you can use volatile anesthesia. And so sevoflurane is super common. Like you're going to use that on 90% of your cases. You do have desflurane and isoflurane. So isoflurane is older and it's very slow on and slow off, which makes it somewhat unappealing, but it's there nonetheless. And so, and for me, I just wanted to try it and see how it worked, see if I like it. I know that it's not used super frequently. It's used in cardiac anesthesia and neuroanesthesia, but that's really about it. And so I really wanted to try it and just get used to it. But if you're going to be using gas anesthesia, determine what kind of gas you're going to use. Sevoflurane would probably be the most common one. Desflurane is very fast on and very fast off, but it is a respiratory irritant. And so you don't want to use it on somebody that has asthma or that smokes or has COPD or has any kind of airway pathology, because it will just cause airway irritation. And after extubation, they could be coughing, they could have that sympathetic response with tachycardia and hypertension. So typically we avoid desflurane in patients with any kind of airway issue. So asthma, like I said, COPD, or smoking history. And so that's kind of my personal guideline. So if I'm doing gas anesthesia, I'll use sevoflurane. Side note, you can also use sevoflurane for an inhalation induction. And so we talked about earlier giving the fentanyl and the propofol and the rocuronium that renders a patient unconscious. You can also do what we call an inhalation induction, and that's using the volatile anesthetic. So you'll put the mask on the patient, have them take some deep breaths as you're turning the gas on, and that will also render them unconscious. And then you could paralyze and intubate. Sevoflurane is the only volatile anesthetic that we can use for an inhalation induction, because isoflurane is also a respiratory irritant, just not to the extent that desflurane is. So we're not going to use desflurane or isoflurane for an inhalation induction. Sevoflurane would be the only one that we would use for that.
Hey, future CRNA, another daily dose of inspiration from a CRNA School Prep Academy student. After 3 years of applying and a lot of rejections, I finally got an acceptance letter to one of my top choice schools. Coming from a background of being told and treated like I'm not good enough for most of my life, the mental gymnastics I had to do was real. For the past 3 years, I have purposely been putting myself in a position to be told I'm not good enough. And I was told that many, many times. The difference is, since becoming a nurse, I know that I am good enough. My socioeconomical and educational background was not so great growing up, and nursing was my second career. When I was younger, I lacked confidence in my educational capabilities as a young adult, and it was not until I went back for nursing that I realized I could be smart enough. I wrecked my GPA when I was younger, so I had to work hard to correct it. I did that in nursing school with my BSN, but I had to be extra aware of what programs use the last 60 credits or nursing degree calculations. Despite having 6 years of ICU experience and 10 years overall, I had to return to the ICU to gain recent experience, which when you have a cushy IR cath lab position was no easy task. But I can say now that it was worth it. I'm going to do this, and I cannot wait to get started. I would like to thank CRNA School Prep Academy and all the resources and support that is available. Thank you, Jenny and Richard, and everyone else for making our dreams a possibility. Start date, June of 2023. SRNA signing out. Congratulations, CSPA student. If you're listening, I know who you are. I'm so incredibly proud of you. I know you've been at this for a long time. So those of you listening to this story, if you can relate to the feelings of not being good enough, I hope this story hit home. And let me remind you that you are too capable of achieving your dream of becoming a CRNA. If you're not already signed up for our free Future CRNA newsletter, be sure to do so now. Pause this episode and go click the link in the show notes in the comments below. Cheers to your future. I'm rooting for you. Now let's get back to the show.
And so the other option is a TIVA, total IV anesthesia. And most commonly, we would use propofol for this. Typically, you can get away with doing propofol and then working in some fentanyl or ketamine throughout the case as well. You wouldn't just want to use propofol because you don't have any analgesia there as well. So you would have to supplement the analgesia in some form or fashion with either IV opioids or Tylenol or Toradol, using your adjuncts as well. You can also if you're doing a TIVA, you could also use remifentanil, which is a very fast acting opioid that's metabolized by nonspecific esterases, and so it's got a half of like 3 to 5 minutes, so it's very fast on, very fast off. And we usually use the TIVAs in spine cases. And so whenever we think about the maintenance phase, we really want to know one big question, and that is, will there be neuromonitoring? And so if there's neuromonitoring, that's very common on any kind of spine surgery. So cranies, necks, backs, anything like that, you're going to be doing neuromonitoring, or around the thyroid where the recurrent laryngeal nerve resides on each side, you would be doing neuromonitoring for that as well. And most often we opt for TIVAs with that because our gas interferes with neuromonitoring. Paralysis also interferes with neuromonitoring. So we're not paralyzing those patients. We may paralyze initially to facilitate tracheal intubation, but through the procedure itself, we're not going to be paralyzing. And so if you're going to be doing a spine case, and these are types of things that you learn in school, this is not something that you would just be expected to pull out without ever learning in school. You would know that if you have a spine case coming up, you're probably going to be doing neuromonitoring and you need to do a TIVA. Now, with some neuromonitoring, you can do what we call a dirty TIVA, which is like a half a MAC of gas and then a propofol infusion at like half of what we consider a MAC. So usually about 100 mics per kilo per minute is considered a MAC. So we would do maybe 50 mics per kilo per minute plus a half a MAC of gas, and you could usually get by with neuromonitoring. However, the safest option for the neuromonitoring is to do a complete TIVA. So propofol infusion, remifentanil, with some ketamine or Precedex or whatever other adjuncts you want to use. And so just know that if you're doing something neuro related where there needs to be monitoring, you'll be doing a TIVA. And just there are a million different ways to do a TIVA. Time would fail us to talk about all the ways to do a TIVA. So just know, big broad general, you'll be doing a TIVA if you need neuromonitoring. And then the next question during maintenance is, does the patient require ongoing paralysis? And so if you're in a laparoscopic case, the chances are they will require ongoing paralysis. And so you're going to have to redose your rocuronium, or you're going to have to give them some vecuronium or cisatracurium, whatever you want to give. Give them something long acting, not succinylcholine. We don't want to paralyze them for 5 minutes and it come right back. So give them something longer acting so that they will remain paralyzed. And then think about pain control during this phase as well, during the maintenance phase. Am I working in some adjuncts? So am I giving IV Tylenol, IV Toradol? Am I giving magnesium? Am I giving like the analgesic dose of ketamine? Or am I going to be working in some Dilaudid or some more fentanyl? Think about those things during the maintenance phase. How am I going to control their pain? And so that kind of wraps up the maintenance phase. The really big questions that I would ask myself during maintenance are, am I going to be doing gas? Am I going to be doing a TIVA? And do they require ongoing paralysis? And that will kind of guide you in the appropriate way. If the patient doesn't require ongoing paralysis, and they're doing some kind of spine surgery, you want to keep the patient deep, because the last thing you want is the patient bucking or moving around if they get too light. And so you really want to stay on top of your drips and your biz monitor. Your biz monitor will monitor that level of anesthesia. You really want to stay on top of those things and know that if the patient's getting light, get them deep, because the last thing you want is them bucking around, because they're not paralyzed. They will absolutely start moving if they get too light on anesthesia. And then we move on to emergence and extubation. And so there are really two broad schools of thought when it comes to emergence and extubation. We'll walk through emergence first. And so emergence is going to be emerging the patient out of that deep plane of anesthesia. And the two different ways of doing that are we going to be doing a deep extubation, or are we going to be doing an awake extubation? And there's really so much that we could cover in regards to deep and awake extubations, and we'll save that for another episode. However, I will say this: if you're doing, the reason we do deep versus awake is the patient is able to follow commands. They're able to open their eyes. They're able to lift their head off the bed. They're able to squeeze your fingers. And we would know that if we're waking somebody all the way up, that they're able to protect their airway so that when we pull the ET tube out, they can spontaneously breathe and they can protect their airway, meaning they're at a low risk for aspiration. Now, on the counterpart to that, you can do what we call a deep extubation, which is where the patient is still in stage 3 anesthesia. They are under a full MAC of gas, or they are breathing spontaneously on their own, and we would pull the tube then and let them slowly, after the tube is out, slowly blow off that gas with a face mask of oxygen on, take them to PACU. Those are the two different ways to wake somebody up. And this again is going to be largely dependent on the institution where you either work or where you're rotating, doing your clinical rotations. So what is the culture there? Is the culture to wake everybody up all the way up? Or is the culture to do deep extubations? Where I'm at right now, the culture is to deep extubate anybody that's appropriate. So those patients that we would not deep extubate, and that's really the question. How are we going to wake this patient up? What are the contraindications to each? So contraindications to an awake extubation, there's not really any. Like, you could wake anybody up and you wouldn't be wrong. Now, if you're doing a deep extubation, you don't want to do that on somebody who is at a high risk for aspiration. So again, somebody with a full stomach, somebody that has the autonomic neuropathy, gastroparesis, on semaglutide, things like that, has GERD. We don't want to risk that aspiration. So we would wake them all the way up. They're able to follow commands. Then we can pull the tube and they can protect their airway. They could still potentially aspirate, but the risk is significantly lower than that of someone who we deep extubate and they don't have control over their own airway. They're still out. They're still in stage 3 anesthesia and they're still blowing that off. So deep extubation, anybody that's full stomach or at risk for aspiration, we don't want to do that. Also, somebody that's a difficult mask. And so this really comes back to induction. Whenever we give our induction meds and our paralytics and we're bagging the patient, how easy of a mask is it? Can we bag them effectively? Can we exchange? Do we have positive end tidal? Or are they a difficult mask? Like, are you not getting any exchange? Do you have to two-hand mask? If they're a difficult mask, then you don't want to deep extubate somebody, because one of the risk of doing a deep extubation is if they spasm, if they have a laryngospasm, you would need to be able to mask the patient. And again, this is not the episode to talk about all the complications of anesthesia and emergence and extubation, but I'm just briefly touching on them. So if they are an aspiration risk, if they are a difficult mask, or if they're a difficult airway. So if you go in and look with your DL, you can't get the tube in, you have to get the glide scope, probably best to wake that patient all the way up, because if something happens and you have to re-intubate the patient, then you would have a less of a risk of having to re-intubate the patient if they're already awake and protecting their airway, versus if you pull it deep and then they spasm and then you go down that road of having to break the spasm, you can't break the spasm, now you have to re-paralyze them and intubate them. So anybody that's a difficult airway, difficult mask, high risk for aspiration, don't deep extubate them. And again, this is largely going to be dependent on your institution, where you're rotating, and what your preceptor's comfort level is as far as doing wake ups and extubations. And so that's the broad 30,000 foot view of how we develop a plan of care for that emergence extubation phase. I will briefly touch on this. You don't want to wake somebody up in what we call stage 2. So stage 2 of anesthesia is that hyperactive stage. And so that's where the patient is transitioning from that deep plane of surgical anesthesia, there's not an autonomic response, to that hyperactive phase where they're coughing and they're bucking and they're breath holding and they're tachycardic, and you can see them like moving a little bit. That's stage 2 anesthesia. If you pull the tube in stage 2 anesthesia, you'll absolutely get a laryngospasm and you'll have to break that. So either deepen them, get them in stage 3, or wait for them to wake all the way up. They can follow commands, they can open their eyes, move their hands, do whatever you say, and then you can pull the tube. They're out of that stage 2, that hyperactive, hyperreflexive state. And so that really is what it comes down to. And a good way to assess that is to either wiggle the ET tube or deflate the cuff and then inflate the cuff. If you see them breath hold, or if you see them kind of gag on the ET tube or move, then they're not deep enough. You should be able to wiggle the ET tube, pull the air out of the balloon, and the patient not move, not do anything. Then they're deep enough. And typically that's going to be at about a MAC to a MAC and a half of gas for them to be at that deep plane of anesthesia for you to extubate successfully. So after we pull the ET tube, then we will wheel the patient off to PACU for them to wake up. There are a few things that we need to consider, and that is some of our like adjunct pain medications. What have we given for adjunct pain? Have we given IV Tylenol, Toradol, magnesium, Precedex, ketamine, and then our antiemetics as well? Have we given Zofran? Have we given Decadron? Do they have a history of PONV, so postoperative nausea and vomiting? Do they have a scope patch on? And these are things that you would also think about during induction and that or preoperative phase as well. What do I need to do to address that history of postoperative nausea and vomiting? So that's a very, very broad general overview on how I develop plans of care when I'm presented with a patient like day one, like show up, here's your lap chole, or here's this, what plan are you going to do? What plan are you going to implement to safely take care of the patient? A very broad overview. Maybe we'll do subsequent videos on getting deeper into some of those issues, because again, there's so much that we could talk about at induction. There's so much we could talk about through maintenance, and there's so much that we could talk about at the emergence and extubation on how to manage those emergencies. So thank you so much for listening in. If you are new here, thank you for listening. If you're a return visitor, or if you're a return guest, thank you also for joining in and listening. Comment below. Let us know if there are any topics that you want me to cover. I would be more than happy to talk about them. Thank you again for joining in, and I'll see you next time.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.